Professor Sarin, Professor Omata, Professor Lau, distinguished colleagues, it's a great pleasure and privilege to welcome you all today. Worldwide, nearly 260 million people are living with HPV infection. Despite remarkable advances in diagnostics and therapeutic technologies, only approximately 13% of HPV-infected individuals are diagnosed, and merely 3% of those diagnosed are receiving treatment. Undiagnosed HPV infection continues to result in chronic hepatitis, liver cirrhosis, and hepatocellular carcinoma, representing a major global health burden. Recognizing this challenge, WHO has established ambitious targets for elimination of wild hepatitis by 2030, aiming to increase diagnosis rates to 19%, treatment coverage to 80%, and significantly reduce hepatitis-related mortality. Countries around the world are actively working toward these important goals. In parallel with sister associations such as ASLD, APASL, and APASL remains fully committed to advancing the field through the continuous revision and updating of clinical guidelines on wild hepatitis. Today, we are gathered here to update the guideline on chronic hepatitis B infection. I firmly believe that the scientific discussions and collaborative spirit of this meeting will contribute significantly to the future of HPV management and inspire further innovation in our field. I would like to also express my sincere appreciation to Professor George Lau and his team for their outstanding efforts and dedication in organizing this important meeting. I wish you all a highly productive and successful meeting. Thank you very much.
Good afternoon, ladies and gentlemen. Welcome to this very important session. I'm Jing Chen from CU Hong Kong, and personally, I'm thrilled to be part of these significant initiatives on the 2026 update of APASL Clinical Practice Guidelines on the Management of Chronic Hepatitis B. It is quite a journey to work together with the top experts in our Asia-Pacific region to get this done. So, why do we need updated guidelines? First, let's look at the scale of the problem. The Asia-Pacific region is the global epicenter of chronic hepatitis B, home to more than 2/3 of all patients worldwide. 8 countries bear the most burden, accounting for nearly 90% of cases and deaths. Despite this, diagnosis and treatment rates remain shockingly low, often below 15%. This is due to a multitude of barriers, including difficulties in linking patients to care, high treatment costs, social stigma, and inadequate healthcare resources. This immense burden highlights the urgent need for action. Our understanding of CHB has evolved dramatically. The once believed immune-tolerant phase is now understood to be potentially progressive, carrying a real risk of liver cancer even with normal ALT levels. This shift is supported by new tools such as quantitative biomarkers like quantitative HBsAg, HBV RNA, and HBV core antigen, which provide insights into viral activity and cancer risks. Additionally, non-invasive fibrosis assessments are changing how we monitor liver damage. The patient profile itself is also changing, with more HBe-inactive adults and immune-tolerant younger patients. These changes necessitate a fresh approach to patient management. In the meantime, the therapeutic landscape has changed significantly, with safer, more effective treatments now become standard of care. New evidence supports treating patients earlier and exploring combination therapies. Patient care is also more complex due to the high prevalence of coexisting conditions like NASH, NAFL, or MAFL. Furthermore, the exploding development of AI and machine learning, which we're all experiencing, are beginning to play a role in personalized medicine. Therefore, to address these new realities, there is an urgent need for simplified, evidence-based guidelines that can be applied across the diverse Asia-Pacific region to improve patient outcomes and move us closer to the global elimination goal. So in the following sessions, our panel members will share with you the recommendations for CHP management in key clinical questions in the following 7 categories that we think are most relevant and will make the impact: screening, testing, vaccination, treatment, HCC surveillance, prevention and reaction, open question, and future direction. So, ladies and gentlemen, in this beautiful Istanbul, we hear officially release of CHB's CPG 2026. Hopefully, these updated guidelines can transform CHB management by revolutionizing service delivery and clinical practice. Hopefully, together, we can eliminate viral hepatitis sooner than later. Thank you.
I'm George Lau, the corresponding author of APASL Chronic Hepatitis B Clinical Practice Guideline 2026 and update. My research interest is mainly in immunotherapies and formulations of clinical practice guidelines in liver diseases. This is the disclosures of conflict of interest. I'm currently the senior consultant in gastroenterology and hepatology at the Humanity and Health Medical Center, Hong Kong, SAR, China, and also play a role as the principal investigators conducting clinical trials in various aspects related to liver diseases and oncology at the Humanity and Health Clinical Trial Center, Hong Kong, SAR, China. This APASL Clinical Practice Guidelines on the Management of Chronic Hepatitis B Infections was the conjoint effort by over 40 experts, key opinion leaders in Asia-Pacific regions. The first authors of these guidelines was Professor Yao Hong from China, Professor Mao Reki from India, and Professor Chen Jing from Hong Kong SAR. Me, myself, Professor S.K. Sareng, and Professor Marcio Omatus were the senior authors. This guideline formulations was supported by the expert panel formed on behalf of APASL Viral Elimination Task Force. The key opinion leaders in Asia-Pacific regions were selected based on their significant clinical experience and research contributions in the field of chronic hepatitis B, and they are required to comply with the APASL conflict of interest policy with full disclosures, and those individuals with research activities or publications primarily driven or sponsored by pharmaceutical companies were excluded. The chairmanships of these expert panel formations were me, myself, Professor S.K. Sareng, and Marcio Omato. The key opinion leaders was recruited from the APASL's members in Asia-Pacific regions, from Hong Kong, Japan, mainland China, Malaysia, Pakistan, South Korea, Taiwan, Philippines, Australia, and also Singapore, Indonesia, Inner Mongolia, and also Egypt and Turkey. The initiations of these APASL Chronic Hepatitis B Clinical Practice Guidelines was started at the closed-door meetings conducted in March 29, 2025 at Beijing during our APASL annual conference conducted over there. First of all, key clinical questions related to the daily management of chronic hepatitis B was identified by the key opinion leaders, and then the divisions of labors to answer these questions was formulated by all the experts, and they have to conduct comprehensive literature reviews to support an answer to these questions. And the recommendations was then formulated and discussed further. Consensus on the final recommendations was achieved through the structured discussions among the panel members, with further multiple rounds of online and in-person meetings. Specifically, a hybrid meeting was conducted in Hong Kong in September 2025 to finalize the consensus on the recommendations. All the recommendations was based on evidence, and these gradings and formulations of recommendations was based on grade. Final approvals was obtained from the steering committees of APASL on the 8th of November 2025 at ASLD annual meeting, Washington, D.C., USA. And the manuscripts was submitted to Hepatology International's, the official journals of APASL, in November 2025, and then further revised and finally accepted on the 22nd of February 2026. Public announcements of these recommendations by the various key opinion leaders was presented at the APASL annual meetings conducted in Istanbul in 2026 April in Turkey. Finally, the acknowledgements. These guidelines were supported by the people, for the people, and to the people. Thank you.
Good day to everyone. My task for today is to give you the section on vaccination, screening, and testing. I'm Dr. Diana Payawa. Let's start with the first question. In newborns, what is the optimal timing of the first dose of hepatitis B vaccine to prevent perinatal transmission of hepatitis B virus? It carries 6 rationale. Firstly, the timely birth dose prevents perinatal hepatitis B virus transmission. Vaccination should be given within 24 hours, which confers substantial protection. And for S antigen positive mothers, vaccination should be given within 12 hours plus HBIG, because this confers less than 5% transmission risk from mother to child. Once you complete the full series of vaccination, it ensures durable immunity and long-term protection. And the conventional 3-dose carries a 0-1-6 months to be completed within 6 months. And if there is an accelerated schedule, it should follow the approved product labeling. With this, you intercept mother-to-child vertical transmission, and it carries 3 tiers. On the first trimester, the universal S antigen screening for all pregnant persons should be done. 28 weeks, then the third trimester, you evaluate maternal viral load. And if hepatitis B virus DNA is more than 200,000 IU per ml, initiate tenofovir to suppress virus prior to birth. And on birth to 0 to 4 hours, an infant received HBIG plus hepatitis B vaccine dose for S antigen positive mothers. And the shared decision-making should be done, and for infants born to S antigen negative mothers, providers and parents may opt to delay the birth dose until the infant is more than 2 months of age, based on individual infection risk transmission or risk profiles. Therefore, to answer the first question, in newborns, what is the optimal timing of the first dose of hepatitis B vaccine to prevent perinatal transmission? Recommendations are as follows. The first dose of hepatitis B vaccine should be administered to all clinically stable newborns within 24 hours. For infants born to S antigen positive mothers, the vaccine should be administered within 12 hours of birth, preferably together with hepatitis B immune globulin or HBIG. And lastly, completion of full vaccine series according to the standard schedule is necessary to ensure long-term protection. These 3 recommendations carries an A1 recommendation. Let us answer the second question. In vaccinated individuals, is post-vaccination serological testing necessary to confirm immunity? When you have given the 3 standard dose vaccination series and would like to know whether this serological testing is necessary, you actually tier your patient either a long risk group, a low risk group, or a high risk group. On the left side of your screen, this is the general population in infants. You confer a high efficacy, more than 90% of healthy adults and more than 95% of vaccinated individuals or infants achieve a protective anti-HBs of more than 10 IU per mil. This activates the immune memory, which persists despite antibody decline, ensuring a rapid protection upon exposure. On the right side of your screen are high-risk groups. They are the following: immunocompromised. They have a lower response rate and a faster waning immunity. For HIV population, the response is actually inversely correlates with CD4 count and viral load control. For healthcare workers, testing required for occupational safety documentation. And for those whose household contacts and sexual partners, you complete vaccination series and test 1 to 2 months after the final dose to confer protective immunity, that is an anti-HBs of more than 10 IU per mil. And for infants of S antigen mothers, testing is at 9 to 12 months or delay to avoid false positive from maternal S antigen lasting up to 7 months. 5 to 10% may fail prophylaxis despite HB plus vaccine, and anti-HBs of more than 10 IU per mil confers protective immunity. And for those less than 10, it requires booster and retesting. Looking at this strategy, in vaccinated individuals, is post-vaccination serological testing necessary to confer immunity? The following are the recommendations. First, routine post-vaccination serological testing is not recommended for healthy individuals following hepatitis B or other standard vaccination, given the high immunogenicity of current vaccine, and this carries an A1 recommendation. However, for testing is recommended for populations at risk of inadequate vaccine response or clinical consequences if unprotected. It recommends the following. For immunocompromised patient, test anti-HBs 1 to 2 months post-vaccination and repeat vaccination if less than 10 IU per mil. This carries an A1 recommendation. For healthcare workers, you test anti-HBs 1 to 2 months post-vaccination and repeat vaccination if less than 10 IU per mil. Test S antigen if persistently non-responsive. It carries an A1 recommendation. For infants of S antigen positive mothers, combined testing of S antigen and anti-HBs should be performed 1 to 2 months after completion of the full 3 dose of hepatitis B vaccine series to assess the effectiveness of immunoprophylaxis. This carries an A1 recommendation. And lastly, for household and sexual contacts of S antigen positive individuals, test anti-HBs 1 to 2 months post-vaccination and then repeat vaccination if less than 10 IU per mil. This carries an A2 recommendation. The following are the hepatitis B vaccination in special populations. These are modified dosing strategies and monitoring strategies that are recommended. For hemodialysis, for chronic liver disease, for HIV immunosuppression, for healthcare workers, for those with organ transplant candidates, and for patients with diabetes mellitus. Let us now go to the third question. Should patients' hepatitis B vaccination booster doses be given to individuals who have completed the primary vaccination series? After vaccination, the anti-HBs antibody levels naturally decline over time. which is actually expected and should not be interpreted as a loss of protection. Although these circulating antibodies decrease, the immune memory persists through memory B cells and T cells. So when exposed to hepatitis B virus, these memory cells rapidly produce protective antibodies, preventing clinical significant infection. Therefore, the recommendation for general population, because it carries a long-term protection of more than 20 years, rare breakthrough infections, and clinical disease. Therefore, no booster is needed. For healthcare workers and immunocompromised individuals who have weaker or waning immunity, the recommendation is to to test for anti-HBs, and if the anti-HBs is less than 10 IU per mil, to give a booster doses. Therefore, the key message for this slide is that for general population, no routine anti-HBs testing and no booster are needed after a complete primary series. But for high-risk groups, you monitor the anti-HBs periodically and administer a booster when anti-HBs is less than 10 IU per mil. This is why do we need booster doses? Because of the following current consensus. First, as I mentioned, the evidence for immunological memory is seen when boosters are recommended for hemodialysis and HIV and organ transplant recipients. And lastly, for infants and adolescent cohorts in Asia, WHO in 2024 no booster is needed for healthy vaccinated children through adolescent. And the studies in Taiwan, China, and South Korea confirmed sustained protection of more than 20 years post-infant series. Therefore, to answer the third question, should hepatitis B vaccination booster doses be given to individuals who have completed the primary vaccination series? The first recommendation is that routine booster doses are not recommended for immunocompetent individuals who have completed the primary hepatitis B vaccination series and demonstrated an adequate immune response. This indeed carries an A1 recommendation. And for booster doses should be considered for high risk or immune compromised individuals when anti-HBs concentration falls below 10 IU per mil. In such individuals, post-vaccination serological testing can guide the need for a booster dose. And this indeed carries also an A1 recommendation. Thank you for your time.
Good morning, esteemed colleagues. I'm Min Long Yu from Kaohsiung Medical University, Kaohsiung, Taiwan. When we talk about eliminating hepatitis B, we are talking about a race against time for millions of HBV patients across the Asia-Pacific region. But we cannot treat what we do not find. So that is why screening is the absolute gateway to elimination. Today, on behalf of the APASL viral elimination task, I'm pleased to present our updated clinical framework on who we must test and how we must test them to bridge the massive gap between infection and care. Let's begin with the why and the who. Historically, the global approach has relied heavily on risk-based targeted screening. While identifying the high-risk groups such as patients undergoing immunosuppressive therapy, individuals with HIV or HCV co-infections, or incarcerated population remain clinically vital to prevent reactivation and transmission, it is no longer enough. The data is clear. The risk-based screening alone misses up to 2/3 of all chronic HBV infection patients. In the Asia-Pacific region, where the prevalence rate of HBV remains very high, about 2%, we must pivot toward universal screening to hit the WHO 2030 elimination targets. Health economics show us that universal screening is highly cost-effective even in low prevalence setting down to 0.3%. Universal screening reduces undiagnosed cases, enable early interventions, and low transmissions. Normalizing testing mitigates stigma and ensure equitable access. Furthermore, we must never lose sight for maternal screening. Universal first trimester screening, coupled with timely maternal antivirals and infant immunoprophylaxis, remain our ultimate weapon to break the cycle of mother-to-child transmission of hepatitis B virus. Based on this robust rationale, the task force put forward two recommendations. Recommendation 2.1.1, universal HBV screening should be offered at the population level at least once in adulthood for all endemic regions with a prevalence rate of 2% or more. This carries a B1 grading. Recommendation 2.1.2, concurrently, targeted risk-based screening must be aggressively pursued for anyone at increased risk, regardless of age or country of origin. As detailed on the slides, this comprehensive high-risk list spans from the patients on chemotherapy, immunotherapy, or checkpoint inhibitors to household contacts, individuals with elevated LOT level of unknown origins, and the migrant population living in low prevalence countries. Now, how do we implement this effectively? Undoubtedly, the hepatitis B self-antigen remains our undisputed gold standard for detection. However, a single marker does not tell the whole story. We need a multi-layered diagnostic approach to accurately chart a patient's status. Evaluating the total anticore antibody, especially IgG anticore antibody, allows us to identify exposed individuals, assess the risk of occurring infections, and flag those at risk of viral relapse during the immunosuppression therapy. Anti-hepatitis B surface antigen antibody confers immunity, while the E antigen and LOT will guide our clinical staging. However, the real bottleneck in clinical practice is the gap between a positive screening test and the viral load quantification. Because HBV DNA testing often suffers from limited access or delayed ordering, patients fall out of the care cascade. To solve this, the task force advocates for the implementation of reflection testing. If a sample is surface antigen positive, the lab should automatically trigger an HBV DNA quantification. This simple operational change would drastically accelerate the timeline to treatment. To conclude, our diagnostic recommendations are straightforward. Recommendation 2.2.1, the initial screening panel must include at least surface antigen and total anticore antibody. This is the core A1 recommendation that provides the baseline data we need. Recommendation 2.2.2, to maximize linkage to care, healthcare system should implement the reflex testing to automatically initiate the HBV DNA testing on all surface antigen positive specimens. By expanding who we test through adult universal screening and streamline how we test through the reflexing diagnostics, we can transform this clinical guideline into save lives across the Asia Pacific. Thank you very much.
My name is Yoonjun Kim from Seoul National University, and my task is assessment of liver fibrosis. Gold standard is clearly biopsy to assess inflammation, fibrosis, steatosis, and iron overload. It has several pros, such as accurate disease pace and prognostic information. However, several cons, such as invasiveness, cost, and sampling variability and risk exist. So we recommend non-invasive tests as first-line diagnostic tools, such as serum biomarkers and imaging techniques. It detects advanced fibrosis and cirrhosis, and it has pros such as practicality, safeness, reliability, and repeatability. However, we reserve biopsy for uncertain etiology, discordant NIT results, and concomitant conditions such as MAPLE-D and HDV infection. So, recommendations, liver biopsy is the gold standard for diagnosing the extent and severity of inflammation and fibrosis in patients with CHB A1. Non-invasive tests are preferred as first-line assessment for detection of severity of fibrosis in patients with CHB B1. Liver biopsy should be individualized for patients with discordant non-invasive test results or concomitant etiologies and/or metabolic comorbidities where the diagnosis may alter treatment decision and prognosis. C2. Non-invasive tests using a combination of blood tests and imaging techniques are recommended over liver biopsy for determination of advanced fibrosis and monitoring disease progression. B1. The second question is, how should liver fibrosis be assessed in resource-limited settings, and what is the role of non-invasive tests? We recommend first-line tests. We recommend FIV4 and APRI as first-line diagnostic test, and it has pros such as low cost and wide validations. And we use FIV4 cutoff of 1.3 to indicate a significant fibrosis, while we use 2.67 to indicate strong advanced fibrosis or cirrhosis. And we use APRI cutoff around 0.5 to predict significant fibrosis, and we use around 1 to predict cirrhosis. And vibration controlled transient elastography should be used supplementary, and because it is more accurate fibrosis assessment, and its cutoff value 7.7 kilopascal for significant fibrosis. So recommendations, blood-based non-invasive tests such as FIV4 or APRI should be used as the primary tools for liver fibrosis assessment in CHB patients in resource-limited setting. Vibration-controlled transient elastography should be used as a complementary tool to improve diagnostic precision, particularly when treatment decision remains uncertain after blood-based non-invasive assessment. B2. Next question is how to identify predominant driver of liver injury in patients with concurrent CHB and MAPLE-D non-invasively. As many CHB patients are getting older, they have several comorbidities such as obesity, diabetes, hypertension, and dyslipidemia. And hepatic steatosis are observed more than 35% of those patients. And it clearly increased risk of cirrhosis, HCC risk, as well as mortality. Therefore, there are several challenges such as ambiguous ALT elevations and indeterminate pace risk, as CHB patients in the indeterminate pace have higher fibrosis and HCC risk than inactive carriers, and unclear benefits, as antibiotics reduce HCC risk in moderate HBV DNA ALT elevation, but benefits are unclear if ALT is high due to MAPLE-D or alcohol. So recommendations, all CHB patients should be routinely evaluated for MAPLE-D. Its components such as obesity, diabetes, dyslipidemia, hypertension, and the degree of hepatic fibrosis using non-invasive fibrosis assessment tools. B2. Patients with concurrent CHB and MAPLE-D should be monitored for liver disease progression and liver-related events, regardless of whether antibiotic therapy has been started. B2. In patients with concurrent CHB and MAPLE-D, biomarkers of hepatic steatosis and fibrosis cannot be used to attribute the primary cause of liver injury to either HBV or MAPLE-D or both. C2.
Dear colleagues, I'm Dr. Jia Hongao from Taiwan. I'm happy to join the APASL Clinical Practice Guidelines on the Management of Chronic Hepatitis B Infection, a 2026 update. My missions is on Section 2, Treatment. I will focus on the treatment goals. So the 4.1, what are the goals of chronic hepatitis B therapy, and what are the surrogate endpoints for the treatment goals? I think the rationale, including the management strategy by using the validated HBV viral markers like HBV DNA, ALT, e antigen, and the quantitative HBsAg. And also the key therapeutic goals include the sustained HBV DNA suppression, ALT normalization, e antigen seroconversion, low HBV DNA, that is less than 2,000 IU per ml, and also HBsAg less than 1,000 IU per ml. And the overarching goal is to reduce the global HBV burden, choose the regimens individualized by using the high resistance barrier nukes for long term, or pegylated interferon alpha, which is a finite therapy. And the clinical outcomes include the nuke-induced viral suppression, reduce the risk, including liver cirrhosis, liver cancer, and cirrhotic complications. The early ALT normalizations within the first year has known to improve the long-term outcomes. Therefore, the long-term endpoints include the functional cure, which is sustained HBs antigen loss plus undetectable HBV DNA by using a finite therapy. And the partial cure is the persistently low HBs antigen less than 100 IU per ml plus a normal ALT in non-cirrhotic and HBeAg negative chronic hepatitis B patients. So the recommendations include the short-term goals. In both e antigen positive and e antigen negative patients who receive antiviral therapy, the primary short-term goal is to achieve sustained undetectable HBV DNA by using the most sensitive PCR method and normalizations of ALT level. In e antigen positive patients, it is desirable to obtain e antigen seroconversion, as this reflects a variable therapeutic response. In e antigen negative patients, the therapy should aim to maintain biological suppression and persistently normal ALT. For intermediate goals, the therapy should maintain biological suppression and biochemical remission, which are validated markers of antiviral therapy with the level evidence of A1. Where feasible, the therapy may aim for functional cure, defined as sustained more than 6 months HBs antigen loss with undetectable HBV DNA after completion of therapy. And when a functional cure is unlikely, achieving a substantial decline in HBs antigen level, for example, less than 100 IU per ml, may be considered a partial cure and an appropriate therapeutic target with the evidence level of B1. For ultimate goals, the public health efforts should aim to reduce the global HBV burden through vaccination, screening, timely antiviral treatment, and the prevention of transmission. The treatment should prevent liver-related complications and ultimately improve survival and the quality of life in chronic hepatitis B patients.
Good afternoon. My name's Alex Thompson from the University of Melbourne and St Vincent's Hospital in Melbourne, Australia. It's a great honour to have participated in the 2026 update to the APASL Clinical Practice Guidelines. Today, I will be discussing a number of the specific recommendations in Section 2 on treatment. Firstly, Section 5.2, what biomarkers should guide treatment? The two key markers I will focus on are HBV DNA and HB surface antigen level. Hepatitis B DNA has been recognised for many years to be a key prognostic marker for long-term outcomes in hepatitis B, predicting both the risk of cirrhosis as well as liver cancer. In the context of antiviral therapy, HBV DNA suppression is a key treatment endpoint. A rising HBV DNA level during nucleoside analog therapy can indicate antiviral resistance. In the setting of pegylated interferon therapy, a limited reduction in HBV DNA is incorporated into stopping rules. Surface antigen levels are now emerging as a biomarker predicting treatment response. In the setting of pegylated interferon therapy, baseline and on-treatment surface antigen levels predict for a higher or lower risk of surface antigen loss. In the context of long-term nucleoside analog therapy and the STOP strategy, low end-of-treatment surface antigen levels predict for surface antigen loss. And then finally, low surface antigen levels are being identified as predicting high response rates in the setting of novel treatments, so identifying patients who are easier to cure. In a little more detail, in the setting of pegylated interferon monotherapy, on-treatment surface antigen levels have been identified as stopping rules. So no decline in surface antigen levels, particularly if combined with a less than 2 log reduction in HBV DNA level, or a surface antigen level of greater than 20,000 at either 12 or 24 weeks in the antigen-positive patients, identifies futility and patients should stop treatment. In the context of pegylated interferon, add-on or switch therapy, so this is in patients who've been treated long-term with nucleoside analog therapy, then the surface antigen level of 3 logs identifies patients most likely to be cured in both Asian as well as Western populations. Now, in the context of the STOP strategy for patients who have been taking nucleoside analogues for e-antigen-negative chronic hepatitis B, we know that the likelihood of surface antigen loss long-term is low, as identified in the very large RETRACT B cohort of over 1,000 patients, with overall surface antigen loss rates of 13% at 4 years. However, ethnicity as well as surface antigen levels can identify patients with a higher likelihood of achieving functional cure. So in white patients, a surface antigen level of less than 1,000 at the end of treatment identifies patients with a response rate of 41%. Amongst Asian patients, the surface antigen level of less than 100 at the end of treatment identifies patients with a 33% chance of achieving functional cure. This is only a minority of patients, however. These thresholds were chosen based on a target for surface antigen level of greater than 30% in the context of the STOP strategy. If we push the data a bit harder, so a surface antigen level of less than 100 in white patients identifies a likelihood of functional cure of 75%, and similarly in Asian patients, a surface antigen level of less than 10 international units identifies patients with, again, a 75% chance of functional cure, a smaller subset of the overall patient cohort. And then finally, surface antigen levels are emerging as important in the context of novel treatments. So here is some data discussing bepirovirsen, an antisense oligonucleotide that has recently completed phase 3 development. This is data from the phase 2 study where bepirovirsen was used to treat patients who had achieved virological suppression on nucleoside analogues. You can see that the overall surface antigen loss rate was 9%, but in patients who had a surface antigen level of less than 1,000, the cure rate was 16%. So low baseline surface antigen was a predictor of response in this phase 2 study, and indeed was an inclusion criteria for the phase 3 data that we look forward to hearing more about at APASL in a couple of months. So the recommendations are 5.2.1 HBV DNA with a lower limit of quantification of less than 10 to 20 international units per mil, as measured by real-time PCR, should be tested before and during treatment. And 5.2.2, serum HBs antigen levels should be tested at baseline and monitored during peak interferon, and also for discontinuation, for identification of patients suitable for discontinuation of long-term NUCs. And then secondly, I want to discuss section 5.3, how should treatment decisions be guided by cost effectiveness, long-term safety, and patient preferences. So chronic hepatitis B management is shifting towards broader antiviral coverage. Economic models from China, Korea, and the US have shown that treating low risk or minimally active patients is cost effective for reducing HBV-related complications and mortality, supporting the treat-all strategy that aligns with WHO 2030 viral elimination goals. High-resistance barrier nucleoside analogues should be used to treat hepatitis B using drugs with potent, persistent viral suppression that have minimal resistance. And so the first-line nucleoside analogues are entecavir and tenofovir. And the three different versions of tenofovir we have available, TDF, TAF, or TMF, can all be considered first-line treatments. Note that long-term tenofovir or TDF use is associated with a higher fracture risk than entecavir. TAF offers similar efficacy to tenofovir with superior renal and bone safety, and so is preferred in patients with renal disease, osteoporosis, or older age. And finally, shared decision-making improves adherence and has been shown to address psychosocial burdens associated with stigma, fear of transmission, as well as treatment fatigue, and may also improve mental well-being. So recommendation 5.3.1, treatment should be prioritised for patients at higher risk of disease progression, regardless of HBV DNA level or ALT. Where resources allow, a treat-all approach should be adopted, initiating therapy for chronic hepatitis B patients beyond traditional high-risk criteria. Therapy selection should consider long-term safety and presence of comorbidities, and TAF or entecavir are preferred over TDF in patients at risk for renal or bone disease. And finally, shared decision-making should be integrated into treatment planning, incorporating patient preferences, psychosocial factors, and willingness to commit to long-term therapy. Thank you.
Hello, this is Dr. Hong Yu from Beijing Friendship Hospital, Capital Medical University. Talking about APASL chronic hepatitis B recommendations, today I will focus particularly on the treatment. This is the whole algorithm of the treatment, actually including of the vaccination, of prevention, screening of those high risks and in the population. And for this guidelines, we focused on the patient who should be treated and which medicine to treat and how to monitor of those patients. So in this treatment session, I will focus on 3 clinical questions. The first question is how effective are current therapies? Now we know the NUCs, including entecavir, tenofovir, and TAF, are the first line of NUCs to suppress HBV DNA in the high virological response. Also, pegylated interferon alpha as the finite treatment, particularly for those who will have the surface antigen loss. And here are the recommendations. TAF, TDF, TMF, and entecavir are the first-line NUCs treatment for chronic hepatitis B. For those without contraindications of immune therapy, pegylated interferon alpha can be considered as a first-line treatment. Also, for those NUCs-treated patients with sustained viral suppression and low surface antigen, the addition of pegylated interferon is recommended. And of course, patient has to receive structured education. The second clinical question for treatment is, should treatment be initiated in chronic hepatitis B patients at early fibrosis stage or who do not meet traditional criteria? It is like the iceberg. We saw those patients with clinical stable, but there are still a lot of patients on ongoing necroinflammation, fibrosis, and disease progression. So for those recommendations, like we start the antiviral treatment should be initiated with HBV detection and ALT higher than upper limit of normal. Here we use the 40 IU as the definition. And for those patients with even minimal or no fibrosis, and the patient with a family history of cirrhosis or HCC, and those with MAFD should consider of the treatment. And the second recommendation for starting treatment is particularly for those high risk of patients. That's including of those patients with HCC, liver failure, advanced liver fibrosis, cirrhosis, decompensations, and extrahepatic manifestations, liver transplantation, and for the patient with immune suppressor, and co-infection with HIV, HCV, or HDV. So we prioritized those patients to treat. The third question is, who could be stopped of the treatment? As we all know, we have to balance the benefit and the risks. Also, close monitor of patient to prevent the relapse. Here are the recommendations for the stopping rule. For both E-positive and E-negative non-cirrhotic patient, NUCs can be discontinued until those patients get sustained surface clearance and undetectable HBV DNA. For those E-negative non-cirrhotic patients, those patients has to be undetectable HBV DNA for more than 3 years and may be considered by experienced clinicians. And of course, patient has to closely monitor with DNA and ALT. For those cirrhotic patients, either E-positive or negative, discontinue is not recommended. And we have to follow those surface loss patients like 2 occasions more than 6 months to make sure the surface loss. This is the last slide of the algorithm. Actually here we mention the patient with the high risk we treat. The patient with HBV DNA positive of any of those risks, which here ALT higher than 40, any stage of the liver fibrosis, family history of cirrhosis or HCC, MAFD, so those 4 are the risks we treat. So those are, we're starting to treat in the purple squares. And for those patients, we start treatment, NUCs could be considered. And we treat those patients until they have the undetectable HBV DNA and the low surface antigen. Here we suggest less than 1500 IU. And for those lower surface, we could add pegylated interferon to trying to pursue the functional cure. For the patients who start with pegylated interferon, we monitor them at week 24, and the patient have the lower surface antigen less than 1500. We could continue the treatment, but less than 96 weeks. For those without the good surface, we could switch to NUCs. And of course, either the patient under treatment or without treatment, they should be monitored, plus HCC surveillance. Thank you.
This is Grace Wong from the Chinese University of Hong Kong. How to manage HPV in pregnant women. We recommend to screen hepatitis B surface antigen for all pregnant ladies. If the surface antigen is positive, we will assess the risk of mother-to-child transmission of the virus based on HPV DNA level, ALT, E antigen status, as well as fibrosis status. Mother-to-child transmission of the HPV will be at high risk if the maternal serum HPV DNA level is about 200,000 IU per ml. These women should start tenofovir, either tenofovir disulfoxofimary TDF or tenofovir alafenamide TAF or TAF at week 28 to 32 of their pregnancy. If in the region H big means the hepatitis B immunoglobulin is not available, TDF should be started earlier in their pregnancy, like at week 16. As well, all infants should receive hepatitis B virus vaccine according to the schedule. We recommend postpartum follow-up with regular monitoring of the surface antigen, HPV DNA, and ALT level. And the mothers can continue breastfeeding while they have been taking tenofovir. Discontinuation after delivery within 1-2 months postpartum is recommended together with monitoring of the maternal liver function up to 24 weeks of postpartum period. These are the recommendation statements. 6.1.1 Screen all pregnant women for hepatitis B surface antigen early in their pregnancy. Pregnant women who tested positive for surface antigen should be assessed for antiviral therapy according to standard chronic hepatitis B indications. In pregnant women with E antigen positive and or HPV DNA above 200,000 IU per ml, antiviral therapy with tenofovir, including TDF or TAF, should be given during the third trimester of pregnancy for preventing mother-to-child transmission. In women identified as hepatitis B surface antigen positive during pregnancy, postpartum follow-up testing with surface antigen, HPV DNA level, as well as ALT is recommended to confirm the infection status, assess disease severity, and the need to start antiviral. Counseling and appropriate management should be provided to reduce transmission of the virus to their sexual partners in future pregnancy. Breastfeeding is safe while the mother is on antiviral therapy with tenofovir. Thank you.
Now we move to the special population, patients with concurrent MAFO or metabolic comorbidities. The question is how to manage HBV in patients with metabolic comorbidities. Based on earlier studies, MAFO is associated with a high risk of liver fibrosis progression and HCC. And recent studies, however, show a paradoxical impact of MAFO. On one side, simple hepatic steatosis is associated with a higher probability of functional cure. However, on the other hand, metabolic dysfunctions such as diabetes, obesity, dose-dependently increase the risk of cirrhosis, HCC, and mortality. And among these metabolic risk factors, diabetes is the most important risk factor. Similar finding is also noted in children. Those with concurrent MAFO had a higher probability of functional cure. Based on the above results, lifestyle modification is recommended for those with concurrent metabolic comorbidities, and pharmacotherapy may be provided for those with concurrent diabetes. So excellent recommendations. First, optimal glycemic control should be offered and achieved in chronic hepatitis B patients with concurrent diabetes in collaboration with endocrinologists and primary care teams. Second, lifestyle interventions are recommended for chronic hepatitis B patients with modifiable metabolic comorbidities.
Dear Chairman, ladies and gentlemen, I'm Dr. Sun from the Southern Medical University, Guangzhou, China. My task here is to talk about the treatment in the special population. First, let's focus on the HBV/HIV co-infected patients. We understand for these patients, they have increased risk of cirrhosis and HCC. So for these patients, they need prompt antiretroviral treatment initiation unless contraindicated, regardless of ALT, HBV DNA, CD4 cell count. We need to remind you that pegylated interferon is not recommended for these patients due to the limited efficacy and tolerability. And the treatment must include 2 anti-HBV agents, TAF, TDF, plus lamivudine or emtricitabine. The TAF is preferred in the renal and bone disease. We should always avoid lamivudine and emtricitabine only regimen due to the risk of HBV resistance. For the patient with antiretroviral treatments, we should monitor for hepatitis flare as well as the sustained HBV DNA suppression. So the recommendation for these patients, the antiretroviral treatments should be initiated promptly regardless of ALT, HBV DNA, or CD4 cell count, with antiretroviral treatment regimen requiring 2 antiviral agents active against HBV. The nuke backbone should include TDF or TAF plus lamivudine or emtricitabine. Now let's move to HBV/HDV co-infected patients. The established therapy for this population is pegylated interferon. They can be treated up to 96 weeks. The response rate is 29% virological response at 24 weeks post-treatment. We are happy with the emerging therapy with bulevirtide. The treatment with 96 weeks can achieve very good outcomes, with 50% of the patients achieve HDV RNA response, ALT normalization, as well as the improved liver stiffness. The combination with pegylated interferon with bulevirtide, they can enhance the suppression. For the special population, especially for the decompensated cirrhosis, now we don't have any approved treatment for these patients. The pegylated interferon is contraindicated. The bulevirtide data is very limited for this population. So for these co-infected patients, all the patients with co-infection with HBV and HDV and compensating liver disease should be considered with HDV treatment with pegylated interferon or bulevirtide. The patient with decompensated cirrhosis, they should be evaluated for liver transplantation. Now let's move to the HBV/HCV co-infected patients. For these patients, they also have increased risk of liver-related death and HCC. DAA therapy is recommended for all the HBV/HCV co-infected patients. The efficacy is comparable to the HCV mono-infection patients. We need to remind you that HBV reactivation can occur in around 6 to 24% during DAA treatment. We can use prophylactic nuke therapy to reduce the reactivation. So the recommendation for the HBV and HCV co-infected patients is that all the patients with co-infection should receive under HCV treatment with DAA. For the surface antigen positive patients, we can use prophylactic leucotherapy before the initiation of DAA treatment to prevent hepatitis flare. For the surface antigen negative but anti-HBC positive patients, the close monitoring of ALT, HBV DNA, and surface antigen is required during DAA treatment. That's the end of my talk. Thanks for your attention.
Treatment. In special population, how to manage hepatitis B virus in patients with alcohol-associated liver disease. Complete abstinence is essential, supported by psychosocial and pharmacological intervention to maintain sobriety. Alcohol seems to enhance hepatitis B virus replication. Excess intake of alcohol seems to enhance liver fibrosis and hepatocellular carcinoma. Recommendation: all patients with hepatitis B virus and ALD should be strongly advised to abstain completely from alcohol. Pharmacological aid and structured psychosocial and addiction support should be offered to promote abstinence. A multidisciplinary approach including hepatology, addiction medicine, nutrition, and mental health should be implicated, with structured patient education to reinforce abstinence, adherence to antiviral therapy, and recognition of decompensation. Thank you very much.
From Hong Kong, and today my role is to talk about session 3 on HCC surveillance. So the first clinical question is about risk predictions and how do risk prediction models best guide HCC surveillance. We know that HCC risk scores has been existing for over 2 decades, and some early models include REACH-B, GET HCC, and CU HCC score are developed in untreated cohorts, and these risk scores are still useful nowadays, mainly for identifying treatment-naive patients who may benefit from antiviral therapy. And we also have HCC risk score developed in treated population. The most validated risk score would be PAGE-B scores for Caucasian and also modified PAGE-B score for Asians. And they are based on age, sex, platelet count plus or minus albumin, and they are very useful for identifying at-risk treated patients who may benefit from HCC surveillance. And new models are still needed, so particularly we have to prove the models that is useful in non-cirrhotic patients so that we can refine the surveillance strategy beyond the standard age thresholds, which is at least 40 years old in men and at least 50 years old in women. We have already some newer models in literature, for example, CAM and also WILB scores that incorporate metabolic factors, particularly diabetes, for improving the discriminations. But the challenge here is the risk scores accuracy usually decrease over time when patients receive prolonged NA treatment. So we know that some risk score may have to be recalibrated so that the accuracy can be improved among patients who have prolonged antiviral therapy. So with all these evidence, so we have the following recommendations. So first, 8.1.1. HCC risk scores which integrate age, fibrosis severity, and sex can identify at-risk patients on list eligible for HCC surveillance with a recommendation of A1. And 8.1.2 patients on NUS with intermediate to high HCC risk, which is PHB score at least 10, and or modified PHB score at least 9, should receive HCC surveillance with recommendation B1. And A.1.3 would be interpretation of HCC risk scores should be approached with caution in patients with prolonged treatment duration, at least, for example, over 5 years, or those with diabetes with recommendation B2. And next, it is about surveillance strategies. So the first clinical question here would be what surveillance strategies are needed for those with modified PHB at least 9. So the rationale here is patient with modified PHB score at least 9 will be classified as intermediate to high risk patients, so they should receive regular surveillance. We know that we have benefit of regular surveillance to be improved early detection of HCC, so that more patients can be treated by curative therapy, so that the survival can be improved, and we also reduce the mortality due to HCC. And the current guideline recommend biannual ultrasound with alpha-fetoprotein as the surveillance strategy, but there may be some problem. For example, the limitation on the sensitivity, especially to detect early HCC, and the sensitivity of ultrasound and AFP also reduced in patients with cirrhosis or in patients with fatty liver. So that the inclusion of PCAF2 on top of AFP and ultrasound can improve the sensitivity to up to 90%, and it can also help to detect more patients with early HCC. So with these evidence, we have the following recommendation. First of all, 9.1.1, alpha-fetoprotein and ultrasound examinations are recommended every 6 months with recommendation A1, and 9.1.2, combined testing with AFP, ultrasound, and PCAF2 is recommended to improve early detection accuracy with recommendation B1. The next clinical question will be what surveillance strategies are needed for those post-HBsAg0 clearance. The rationale here is, although functional cure significantly lowers HCC risk, the residual HCC risk persists due to cumulative liver injury, the presence of fibrosis, and also metabolic or epigenetic factors. And patients with cirrhosis face an annual HCC incidence of 2 to 4%, justifying continued surveillance. So the recommendation here is lifelong HCC surveillance with ultrasound, and alpha-fetoprotein is recommended for patients with advanced fibrosis and liver cirrhosis post HBsAg0 clearance every 6 months with recommendation of C1. With that, I thank you very much.
Dear distinguished guests, dear Professor George Lau, due to my scheduling conflict, I cannot attend this year's APASL conference in Istanbul, Turkey. Sorry, I cannot attend today's release of the guidelines in diagnosis and treatment of chronic hepatitis B in Asia. I'm very pleased that Professor George Lau and Professor Hong Yu and other distinguished guests have led the release of Asia-Pacific guidelines on management of chronic hepatitis B. For the pediatric session, I would like to invite my colleague, Dr. Jin Li, to give a detailed presentation on the 5 slides. Dr. Jin Li, he is a highly experienced expert in pediatric hepatitis B, with richer clinical expertise in antiviral treatment for children with chronic hepatitis B. She has also published numerous papers in antiviral treatment and functional cure of chronic hepatitis B in children and infants. Now, let's warmly welcome Dr. Jin Li for her presentation.
Hello everyone, I'm Li Jing. I'm glad to be here with you today. On behalf of Professor Fusheng Wang, I'd like to give a brief introduction about the main strategies for preventing hepatitis B virus transmission based on the latest guidelines. First, prevention of mother-to-child transmission, which remains one of the most important routes of HBV infection. For infants born to mothers with chronic hepatitis B, timely and standardized testing is crucial. Guidelines recommend combined testing of hepatitis B surface antigen and anti-hepatitis B surface 1 to 2 months after completing the full 3-dose hepatitis B vaccination, which is usually done when the infant is 7 to 8 months old in the clinical practice. The purpose of this testing is to evaluate the success of vaccination, identify infants who are either insufficiently protected or already infected early, and intervene promptly. Second, prevention of HBV transmission in other populations. Vaccination remains the primary and most effective method for preventing horizontal HBV transmission. Although nukes can reduce viral load and transmission risk, their additional benefit is limited in the general population where vaccination is widely available. Therefore, routine use of nukes for transmission prevention is not recommended. There is an important exception, however, for healthcare professionals performing APASL. Even a low transmission risk must be strictly controlled. HCP with HBV infection are advised to receive nuke antiviral therapy to maintain undetectable HBV DNA levels, further reducing transmission risk. Guidelines suggest that HBV DNA in such cases should be controlled below 1,000 with undetectable levels as the ideal target. Therefore, our recommendation is routine prophylactic use of nukes solely for prevention. Horizontal transmission is not recommended when hepatitis B vaccination is available. Next, healthcare professionals with chronic HBV infection who perform APASL should receive nukes therapy to maintain undetectable HBV DNA, thereby minimizing the already low risk of patient-to-patient transmission. Finally, I'd like to emphasize the importance of family-based screening. Household members and sexual contacts of individuals with chronic HBV infection are high-risk groups. Screening these populations is of great significance. First, it enables early detection of undiagnosed infections, allowing timely monitoring and treatment. Second, it provides an opportunity to vaccinate susceptible individuals promptly, blocking further intra-family transmission. Therefore, our recommendation is screening should be conducted for all household and sexual contacts of individuals with chronic HBV infection. And screening should include 3 markers to identify current infection, immunity, or susceptibility. Thank you for your attention.
In this section, we will talk about the service delivery aspects of the hepatitis B guidelines, which are in front of you as the new APASL guidelines. Of course, service delivery is extremely important because otherwise the guidelines, the recommendations of the guidelines would not be implemented. So first of all, we will talk about stigma, which is a significant element in hepatitis B patients, and there are various causes for this stigma. There's misinformation about transmission, moral judgments linking HPV to immoral behaviors, for example, fear of disease progression, systematic cultural discrimination legacies. And the impact of stigma, we all understand, it undermines the workers' rights, leads to discrimination, job loss, and psychological distress, and perpetuates public health inequities. Therefore, workplace interventions are extremely important. We urge that there should be clear policies, education, and legal safeguards. Confidentiality in employee support systems are there to reduce fear, and there are educational programs to correct misconceptions and of stigma around hepatitis B and foster inclusion. There should also be legal protections to ensure fair treatment and prevent discrimination. And the outcomes of this would be really a safe, inclusive work environment, employees that are judged by performance and not by health status, and promotes individual well-being and organizational equity. So the management statement states the following. The first one states anti-discrimination policies explicitly covering HPV should be established and enforced, medical confidentiality ensured, and workplace practices aligned with national laws. Job restrictions should be evidence-based rather than stigma-driven. And secondly, regular evidence-based education should be provided to correct misconceptions about HPV and promote supportive workplace environments through awareness, peer support, and clear reporting mechanisms. The second part of this delivery is the access, the enhancement of access to both screening and then to linkage to treatment. For this, various models are available. For example, decentralized care models, which the WHO and other organizations promote quite significantly. This includes primary care and community-based approaches in which increase testing, reduce missed cases, and are cost-effective. In hand, we need simplified diagnostics, and that has been talked about. Point-of-care testing, reflex testing, and mobile tools reduce delays and follow-up losses. Structured referral pathways are then important once a diagnosis has been made, so that specialist, the complex cases can be channeled towards specialized oversight, and the others can be treated in primary care. Following that, I think one of the most important aspects is the availability of affordable treatment, and which then ensures adherence to treatment, because this is extremely important for long-term therapies such as hepatitis B. Integrated therapies strategies can also be considered. For example, MCTC protection, blood safety, workforce safety, and community engagement. We've already talked about equity and stigma, and the goal is to accelerate hepatitis B elimination by 2030 without compromising care outcomes. Thank you.
Dear Professor Michi, the President of APASL 2026, and dear Professor Lau, thank you for kind invitation to join this session. Today, my task is to introduce the functional cure in our updated and HBV guideline. This is Dr. Wei from Beijing. And what is the functional cure? This is a new point in our and the updated guideline. And the definition for functional cure is the primary therapeutic endpoint in chronic hepatitis B. We indicated the hallmark, that is sufficient genomes, and the sufficient knowledge is durable restoration of the immunocontrol. Of course, we have a few of clinical benefits. They are regression of the liver fibrosis and reduce the risk of cirrhosis, decompensation, transplantation, and hepatocellular carcinoma, as well as reduces the new infections and improves the patient's quality of life. We already know we have the limitations for the new agents. Current outcomes for new investigational agents showed limited and non-durable response. And key uncertainty, including durability, differs from the spontaneous traditional therapy, and unknown optimal dosing and host immune restoration. So, guidance for use not ready for broad clinical use only in well-controlled trials. Because of this, and you already see in clinical trial designs, in phase 1, phase 2, phase 3. In phase 2, and the endpoint was based on drug mechanism. And in phase 3 trials, the primary endpoints, including sustained HBV surface antigen loss, plus undetectable HBV DNA, 24 weeks post-treatment. And also the safety profile, we will to do the monitoring, immunofluorescence, and hepatic events. And meanwhile, in our region, we have a few of the barriers in Asia Pacific region. They are persistent gaps, social barriers, and also we suggest the solution. And in persistent gaps, they are prevention and diagnostics, variable access to treatments, and financial constraints. In social barriers, they are limited public awareness, stigma, and fragmental health system coordination. We also mentioned the solution. We can do that by multi-sectional efforts required to maximum impact of the Q and strategies. So, ladies and gentlemen, based on the previous background, and we proposed a few of the management statements on functional cure. The first one is a functional cure should be defined as a sustained surface loss with or without anti-HBs surface and seroconversion, accompanied by sustained undetectable HB DNA at week 24 post-treatment cessation. Second one, functional cure should be considered a validated surrogate endpoint for improved clinical outcomes. Any clinical trials should focus on immune-active surface antigen positive, but to a group of patients, including E antigen positive and E antigen negative patients, with comprehensive safety and monitoring tolerated to each investigational agent. The third one, partial cure can be considered an intermediate therapeutic endpoint, defined as the surface antigen less than 100 IU per ml with undetectable HBV DNA. The fourth one, post-surface antigen clearance, close monitoring for virological relapse should be included HBV DNA and liver biochemistry every 3 months for the first year, then biannually and annually thereafter. Last one, the fifth, not least. In our Asia Pacific region, achieving functional cure requires a multifaceted approach, including policies and of prevention, early diagnosis, and affordable treatment, adequate trained healthcare provider, collaborative research funding, and patient and community education to reduce stigma and enhance engagement. Thank you.
Very good evening, and it's a pleasure for me to present to you the APASL Clinical Practice Guidelines on the Management of Chronic Hepatitis B Infection, which is a 2026 update, and I'll be talking about the future directions. I'm Dr. Rakhi Maiwal. I'm a professor of hepatology from the Institute of Liver and Biliary Sciences. So what we're looking at in the future is the biomarker-guided hepatitis B virus management towards a personalized treatment. We're looking at the key viral markers like the hepatitis B virus RNA, the hepatitis B core antigen, the quantitative HBsAg, which could reflect the intrahepatic covalently close circular DNA activity, enable the precise monitoring of antiviral responses. But what we need is an equitable access to biomarker testing, which is particularly crucial in both the low and the middle income countries. And the integration of the viral and the host biomarkers is something which the future is we are looking forward to, particularly looking at the emerging immunological and the molecular markers which may predict the sustained off-treatment responses, particularly looking at the CD4 and the CD8 T cell activity, both peripherally as well as in the intrahepatic hepatocytes, advanced omics technology, looking at the cytokine profiling, proteomics and metabolomics, which could predict the response to the treatment modalities like the nucleoside agents and analogs and the interferon, and identify the candidates for curative regimens targeting HBsAg clearance and also looking at the HCC prevention. But what we need is the equitable access to both the screening, treatment, and care, and a decentralized care models, looking at the coordination and integration, which could be providing an effective management and reduce substantially the hepatitis B virus burden in the Asia Pacific. The transformative role of AI cannot be forgotten, and we're having different studies looking at the different machine learning and the deep learning predictive analytics models, which can be very informative and can predict the risk of cirrhosis, fibrosis, HCC in patients with hepatitis B, and AI algorithms could also identify rapid progressors, guide the surveillance intervals, and optimize the treatment timing. And what we need is molecular and population level insights with an integration, which is like integrating these viral markers with multi-omics to predict the treatment response and functional cure, and also looking at the population analytics in this. So AI-driven decision support is what the future we are looking forward to, with the clinical decision support systems, integrating these AI models, federated learning processes, and future directions looking at integration of these multimodal biomarkers for predicting the off-treatment responses in patients with hepatitis B. And I would like to thank you for your very kind attention.